Professora, já está transmitindo? Eu vou apertar o botão de gravar e a senhora começa a falar, tá? 3 segundos, para não aparecer minha voz na gravação.
It is beginning. They are taping. Okay. Because people listen to it after. Because it stay on the virtual system of the university. So people can hear after too. Posso começar, meninas?
Sim.
Are you talking Portuguese to the audience, and after I talk in English to present you, okay?
Okay, thank you.
Então, bom dia a todos os que estão aqui para ouvir o professor Martin Gorsky, que eu tenho o prazer de receber nesse seminário do Grupo de Pesquisa do Instituto de Estudos Avançados e Convergentes da Unifesp, o Grupo Science in Circulation. É o nosso primeiro seminário da linha 2, esse grupo de pesquisa tem 2 linhas, esse é o primeiro da linha 2, e eu tenho o prazer de receber aqui o professor Martin Gorsky, que é um historiador, professor da London School of Hygiene and Tropical Medicine, que vai nos falar sobre as políticas do Banco Mundial para a saúde global. Então, é um prazer recebê-lo e é também um prazer receber a audiência aqui. So, I'm very happy to receive you here, Martin, in our seminars of the Unifesp. I'm very, very happy to present you to our audience. Professor Martin Gorsky is a historian, a PhD for social history from the University of Bristol. He is a professor of History of Public Health at London School of Hygiene and Tropical Medicine. He is now studying policies of the World Bank, but he studied the 19th century of England hospitals. This is a very interesting book, which was very important for me to understand the difference between the idea of philanthropy between the Luso-Brazilian world and Anglo-American world. I'm very happy to welcome you here on this virtual room, since unfortunately we had to cancel your research mission to Brazil because of the pandemic, but I hope next year you can come. We try again next year. So welcome to our virtual room. And as we say in Brazil, the word is yours now.
Thank you, Anna, and good morning, everybody. I am very sorry I cannot speak to you in Portuguese, but I hope you can understand what I have to say, and we can discuss afterwards in Q&A. So today I'm speaking also for my colleague Chris Sears, who was the researcher carrying out this work with me. And I want to begin by introducing the World Bank and its work on health. It was founded in 1944 at the end of the Second World War for reconstruction after the war had finished. Of interest to us is firstly its branch, the International Bank for Reconstruction and Development, and this channels loans from the commercial markets for development purposes. Also of interest to us is its branch, the International Development Association, founded in 1959, and this is a fund held by the bank, which offers loans at below market rates to poor countries, again for development purposes. Technically, the bank is part of the United Nations. In practice, though, it operates independently. When it began, it did not lend specifically for health, Rather, its focus was broader economic development, infrastructure, roads, railways, ports, electrification, etc. Only in the 1970s did it begin lending for health, and that was initially as part of its population and birth control program, where it supplied maternity hospitals and facilities. Then, in the 1980s, it began direct lending for health services. We have data from the 1990s on the sources of aid and assistance in global health. And this tells us that in the 1990s, the World Bank was already a major actor, supplying 20% of all global funding for aid for health, twice as much as that of the World Health Organization, the United Nations agency responsible for health. In my talk today, I want to address an aspect of the conventional historiography of the World Bank in the era of neoliberalism, and to focus on the debates of the bank and structural adjustment programs.
Martin, excuse me, Martin. We are not seeing the next slide. I think you didn't.
Which slide?
Is in the first one.
Just the title?
Yes, just the title.
That is a problem, because I'm on slide 3.
Yes.
I don't know what to do. Shall I go full screen and see if that works?
Yes.
What can you see now?
Only the first one. Now it's okay. Now it's the third one. Okay.
Okay. So, Anna, I can't see you, but I will continue to talk.
Okay, no problem. No problem.
Okay, let me go back to the slide which accompanied the introduction to my talk. So this is where I was introducing the two branches, the International Bank of Reconstruction and Development and the International Development Association. I was describing the slow process by which the bank moved by the 1980s to lending for health. And then I was saying that by the 1990s, it was a powerful actor in assistance for health. Okay, so I hope you can see the slide, the conventional historiography. Is it okay?
Yes, now it's okay.
Okay, perfect. So the literature which I'm going to look at today is critical of the behaviour of the bank in the neoliberal era, the era of structural adjustment programs. This was a period in which, when the bank lent money, it imposed conditions onto countries which borrowed, that they should move their economy towards a more free market position, that they should remove tariffs on trade, they should reduce state expenditure. Their aim was to encourage the development of private markets and to improve productivity that way. Also criticised being essentially interests of the Western financial system, which stood to receive their loan repayments. With respect to social spending, the conditionality of structural adjustment meant cuts in welfare. It meant state expenditure was reduced and the wages of the labour force were also reduced. The criticism goes on, in health particularly, that this enthusiasm for the market meant that user fees, in other words, payment out of pocket by patients, was introduced as part of the conditions. And the criticism continues that this meant a commoditisation of healthcare, and it had negative effects on the population. Thus, to sum it up, neoliberal ideology was damaging to the health of the poor. These cartoons capture the idea of the World Bank trapping poor countries, in this case Africa, into a cycle of debt from which it was very difficult to escape, with the effect on poorer users of health services that they were obliged to pay, even at times of desperate need. And so in my talk, I want to examine this episode to try to explain why the bank adopted this policy, which soon proved to be unsuccessful. And I will trace the intellectual history of these ideas, and I will also ask whether it was indeed based on the ideology of neoliberalism rather than evidence. In the first part, I'll explore in more detail this critical historiography. I'll then give a chronological narrative of the history of the policy, and I'll finish with a discussion. We don't really want to revise, it's not a revisionist history, but what we do want to show is it was quite complex. There were continuities in the bank's turn to user fees with earlier progressive ideas. We also want to try and understand why the people behind it saw themselves as working from an evidence base, as being essentially people whose politics were centre-left and who were pro-poor. And to explain that, we want to talk a bit about the institution of the bank itself and how it prioritised certain ways of thinking. So the methods we pursued, and I hope on this slide you can see a picture of the bank's headquarters. It's a traditional historical research paper based on the published literature of the bank, both its own publications, easily available online, and the research from World Bank members in academic journals. My colleague Chris visited the archives of the bank, and we were able to easily access the background papers and the internal documents. And finally, we conducted some oral history interviews, and the bank also already has a good collection of oral history. So it's a mixture of oral history and documentary research. The conceptual framework in which we're working draws on the political science theory of international organizations, which proposes a spectrum of possibilities. On the one hand, the realist school of academic scholars believes that it's not really possible for international organizations to function genuinely in the global interest. The realist school argues that international organizations are always captured by the most powerful of their member states who control them. More optimistically, the functionalist or complex interdependence school of theorists argue that since the mid-20th century, the weakness of the nation state in dealing with global problems means that there is a genuine possibility of international organizations working above and beyond the interests of the nation state, that their bureaucracies take on a life of their own and they become genuinely transnational. Now, with the World Bank, the conventional approach is to lean towards the realist school of interpretation and to see the bank as quite heavily under the influence of the United States. The US appoints the president. It has veto power on the board of the bank. It's the largest contributor to the fund of the International Development Agency, which of course gives it a sort of moral power over where those funds go. And there certainly have been examples of where its lending has followed the interests of US foreign policy. And in our discussion, we will assume that particularly in the early period and the 1980s, it leaned towards the policy wishes of the United States, perhaps less so in the 1970s. We don't want to say crudely that it was simply the creature of American interests. Of course, if it was to have legitimacy, then the United States needed to accept it had a multilateral character. It was also true that the International Bank of Reconstruction and Development borrowed on the global capital markets. It did not draw simply on American resources. The bureaucracy and research capacity of the bank was genuinely independent, and technically its constitution was meant to forbid political considerations in lending. But nonetheless, we would see it as rather more under the sway of the United States, certainly than the World Health Organization, which particularly in the 1970s and 80s became more genuinely global in its approach and distribution of power. Now, let's come on to the next section where I look at the critical historiography in more depth. And I want to introduce this document, Financing Health Services in Developing Countries, a study published in 1987, which in the critical literature is regarded as, if you like, the smoking gun in the evidence of the bank's turn to neoliberal beliefs.
Michael, I'm sorry, Michael. Stop it again.
Go ahead.
We didn't enter in financial health services. The slide of financing health services didn't enter for us.
Okay, let me try again. Did it come?
No. The conventional historiography, critical historiography, I think more one.
It should be the slide headed Critical Historiography, the Smoking Gun.
There is. Okay, critical historiography, the smoking gun, yes.
Oh, perfect. Excellent. Okay, good. Thank you. This study begins with the introduction saying the common approach to healthcare in developing countries has been to treat it as a right of the citizen with free services to everyone. This approach does not usually work. And they then go on to make the case for economists, health services divide into some which should have public funding, taxation, but others which should be in the private sector. And it relates to the theory of externalities. In other words, where a service has positive externalities for the public, then it's best to finance it through taxation. They argue that individual consumers are generally reluctant to pay directly for these programs and services because they don't benefit the individual, they benefit society as a whole. That means things like vaccination programs, sanitation, health education, preventive healthcare, things like that, public goods. But then they argue that some aspects of healthcare should be seen as private goods. That means the individual clinical encounter between the doctor and the patient in the hospital, in the GP, in the surgery. For those, they say, that individuals are generally willing to pay for direct curative care to benefit themselves. There are no externalities for the public. It's simply a service for the individual. And in those cases, private funding, private services were preferable. So there they say countries should consider instituting modest charges. So I hope you can see the next slide. Financing services, financing health services, the rationale.
No, we are not seeing.
How is that?
No, smoking gun yet.
Let me try something else. How's that?
No. Oh, yes. Financing health services. Okay.
Okay, I think what I have to do is come out of screen view and then return when I change it.
Okay.
Okay, so what else do they say in this? They mention the rationale, and it also included other things, other criticisms of the existing system. They argued that it was full of inequities, and particularly there was serious maldistribution between the rural and the urban, and that those publicly funded systems actually favoured wealthy people. They argued it was inefficient and that public spending was inadequate. They argued that it was also inefficient because it put too much money towards hospitals and not enough towards preventive health. And they argued that there was a poor balance between primary care, of which there was too little, hospital care, of which there was too much. So what they were proposing was not just to introduce user charges, but also to decentralise services, to introduce health insurance, and generally encourage private sector provision. I don't want to say that they neglected the interests of the poor. Look at the text. It says that they particularly wanted very low or even zero charges in slum areas and rural areas. So this they regarded as a pro-poor document. Okay, so I hope you can see a slide, user fees literature.
Yes.
And I want to say it very quickly became clear that this policy was not working. Soon a large literature appeared which showed, first of all, that by charging fees, utilization of services fell. In other words, it created a barrier to access to services. Hutton's study of Africa, for example, showed 84 studies showing that utilization fell, particularly for the poor. In 2011, a systematic Cochrane review of the literature by Lagarde and Palmer put some numbers on that by pulling together a small number of robust pieces of empirical research. They could show falls in utilization of between 28 and 50% when fees were introduced, and that when they were removed, utilization would increase by the same amount. The literature discovered that equity gains had been largely unfulfilled and that the poor continued to suffer. And they discovered that new inefficiencies were also introduced to the health system by, for example, things like unnecessary prescribing by doctors in order to gain more of the private fees. So, by the 2000s, sorry, there had been a retreat from user fees, and I hope you can see in this slide Margaret Chan, the director of the World Health Organization, in 2010, really bringing an end to this approach. Reliance on direct payments, she said, by far the greatest obstacle to progress. In the British Department for International Development, Rob Yates wrote more emotively that perhaps more than 3 million child deaths could have been averted had fees not been charged. So now I'll begin the second section, which I'm going to call our narrative historical study. And I'm beginning in the 1950s and 60s with the early period of the World Bank's work. And I want to now show you how they came to this way of thinking. When the World Bank first looked at the role of health in development, it actually assumed that it was not its job to involve itself in health services. Rather, it should concentrate on the main drivers of economic productivity. It should put in place railroads, highways, pipelines for water or oil. It should develop docks. It should concentrate on energy, gas, coal, electrification, the basic infrastructure for economic growth. And the assumption was that health services and schools, etc., would trickle down as a result of economic growth. Now, in the early missions of the World Bank, and actually the first one was to Colombia in 1950, they advised national governments on their approach to development, their planning for development. And in these documents, you always find some advice about health services, even if the bank was not lending for it. You find the beginning of the argument that it should be considered as part of economic development because it was concerned with human capital. And these early development missions also advised that government should concentrate on prevention, on sanitation, water supplies, and things like that. Nonetheless, the bank itself remained at arm's length. It did do some lending for sanitary infrastructure, but nothing for health services themselves. That, at this time, was left to the World Bank, which was involved with its great campaigns against malaria, smallpox eradication, and so on. This began to change in the 1970s, and I hope you can see a slide with some pictures of the World Bank's president, Robert McNamara, who began to change the direction, and under him, health lending started. McNamara had made a successful career in American business, in the Ford Motor Company, where he was a management expert in the new approach of operational research. He then joined the government's Defense Department under President Kennedy. And unfortunately for his career, he was then part of the government's deceptions over the Vietnam War in the 1960s. And this rather blemished the record of his career. One of our oral history participants told us he had been a leading light in the Vietnam War, which didn't go well. Coming to the bank, he wanted to set things right in terms of his reputation. So when he was bank president from 1968, he oversaw, firstly, a growth in the activity of the bank, much more lending, and a new focus on what was called at the time basic needs of the poor. An acceptance that this trickle-down philosophy was failing and that more focus needed to be put on welfare. There was a great expansion of the bank's loans and the beginning of what they called poverty lending to particularly help small businesses, small farmers in rural areas. And this is where the beginning of lending for private schools and community health started. And he also introduced the bank's research function. So in the 1970s, lending for health began, but under the bank's population control program. In his book, The Population Problem, McNamara wrote that population growth then was an even more dangerous threat to the world than nuclear war. So his idea was that countries, developing countries, needed to restrain population and that there should be some lending to support that. Now, partly this was about birth control through education to change behaviour. But a part of this was to introduce family planning in health facilities. And so the very first loan for health that the bank made in 1970 was the Jamaica Population Project. And I hope you can see some slides of the great new maternity hospital in Jamaica, the Victoria Jubilee that was built with that, and also various rural clinics, training for paramedical labour force and things like that. Next slide, towards direct lending. So after that start, the bank then moved to increase its lending for health services. There was a policy paper in the 1970s which first discussed the option of moving to more lending for health services beyond just population concerns. They decided in 1975 not to do that. But in 1980, another policy paper was produced in which there was an agreement to begin direct lending for health. The targets would be primary health care, essential drugs, maternal health, and the prevention, immunisation programs, vaccination against infectious disease, not high-tech medicine in the hospitals. In that paper, the bank made several arguments. First of all, the human capital argument, the rejection of the trickle-down idea, and the claim that for development to succeed, you needed first productive investment in health to encourage a healthy workforce. The document was also highly empirical. It had a great review of the burden of disease in poor countries, tracking the scale of mortality from, for example, malaria, tuberculosis, etc. It also incorporated the argument from the new health economics discipline that health services were not suited to the market. The early arguments of Kenneth Arrow about market failure in health, for example, due to the ignorance of the consumer, due to the problem of the burden of catastrophic health expenditures, even for prudent savers. So these sorts of arguments were considered. There was also great concern with the issue of equity between the rural and the urban, and the cost effectiveness of the spending which came from public sources. Okay, so the next slide, health lending. What I want to say here is that this early move by the bank for lending for health was also quite in line with the broader intellectual trends in global health. There had been at the same time in the World Health Organization and amongst many others a critique of Western medicine as the model for global health. Western medicine, they argued, had globalized essentially in the colonial period. It had meant too much concentration on the hospitals in the cities that were the centers of colonial trade, and it had left rural and poor populations very disadvantaged. And it drew on examples like the China Barefoot Doctor scheme. It drew on examples of community health in Latin America, in Colombia particularly. It drew on an example of community health integrated with economic development in India. All these examples bubbling up from the global south to argue that a new kind of medicine was needed. This culminated in the Alma Ata Declaration of 1978 by the World Health Organization and UNICEF, with the promise of universality, health for all through a focus on primary healthcare. This would be low-tech medicine. It would use not highly trained doctors, but community health workers, traditional practitioners, and so on. So what I'm saying is that in this period, the World Bank's approach was very much aligned with that of other progressive thinking in the United Nations. But, next slide, in the 1980s, the context for thinking about health and development all changed with the arrival of the Reagan presidency in the United States, where here the focus under the Republicans was a political agenda of deregulation and rolling back the size of the state. It was the beginning of the neocon, the neoconservative foreign policy of the US, and a greater reluctance towards its role in the United Nations, what under President Trump, of course, became the America First approach. And after McNamara, the bank too adopted this sort of policy, this sort of turn towards markets. Its president, Clausen, ended the poverty lending and the basic needs approach. Its chief economist, Anne Kruger, was one of the early great advocates of rolling back the state. Her work on rent seeking by bureaucrats and public officials was part of the intellectual weaponry of neoliberal ideas about reducing the role of the state and replacing it by markets. And we first see in the Berg Report on Africa in 1981 these sort of ideas, the advocacy of trade liberalization as a route to development, and the first mention of user fees being introduced in health. And these sorts of ideas really accelerated following the debt crisis, first apparent in Mexico in 1982. And this is really when those structural adjustment programs really first took hold. So my next slide, user fees in theory, 1970s to 80s. Now here I want to say that the health economists at the World Bank were not particularly influenced by these sort of Reaganite ideas. What they thought they were doing was responding to new empirical research. And there were two key areas. First, the new expenditure surveys conducted in lower income countries, places like Philippines, Rwanda, South Korea, Senegal. And what these surveys revealed was that in many households, already very large amounts of private expenditure was going towards healthcare, but not to biomedicine, towards traditional types of healing. And people were very surprised to discover that probably the average household spent perhaps 4 times as much from their pockets as public taxation was already paying. So by the late 1970s, a consensus in global health was already emerging that if only this money could be directed to the most efficient types of spending, to the best types of biomedical care, then that could be a benefit. Then the world, even WHO, should consider this very favorably. The second new form of empirical research focused on user fees and related to the price inelasticity of demand for health. In other words, the question of, if you raise the price of a health service, would it affect demand? And the answer that seemed to be coming from research was that actually demand for health services were price inelastic. I list 3 examples of this research on this slide, conducted, for example, in Malaysia, in the Philippines, in Mali, in West Africa. The types of research were econometric modelling, where the researcher took as the dependent variable the utilisation of a given health service. And it then modelled, getting data from surveys, the variables which might affect utilisation. As well as price, the fees, the other variables were things like distance from the service, the amount of waiting time, the income of the household, the availability of traditional medicine, and things like that. And the results of these modelling exercises seemed to show that actually demand for health services would not vary with the price. Here, for example, is Aiken. Prices appear to have little effect on whether services are used. So the point is that when the turn to user fees came, there was also an assumption that actually it would not damage use of health services, and a genuine belief that actually this was empirically grounded. Now, the other aspect of context for the turn to user fees in the 1980s is a belief that actually the bank was more realistic and less utopian than other actors in global health. On this slide, Financing Health Services Again, there is a quote from one of our interviewees which catches this. It was a wonderful idea, the whole alma ata thing, but it was not based on the real scarcity of resources. Here the participant is actually talking about West Africa, about Mali. You go to a health centre, there's probably not a doctor, there's probably no drugs. The pipe dream of providing everything relative to that reality was very stark. So that is really the context. So we found when we researched the background to the Financing Health Services document that there were several different versions prepared in the 1980s, and that as you went through these versions, there gradually came a greater and greater support for the user fees argument until 1987, when the final version was published. One very interesting internal document we found from 1984, from the point in which an earlier draft was reviewed, we quote here from the senior bank staff. It was felt that the distortions from financing by taxes should be emphasised more, and the opportunity cost of not providing services stressed. The consensus was the paper was too cautionary and a more positive statement should be made in favour of user charges. So our research on the internal background to this document does suggest that the senior staff were putting some pressure on to put to the foreground the influence, the durability of charging. So now just for my final section, and here I want to think about how we could explain this development, not just simply in terms of ideology, not just simply in terms of the Reaganite background of the period, the whole enthusiasm for private markets which emerged at this time, but rather to think a little bit more about the institution itself, about the bank, about the experts who worked within it, and to think about why it was that they were so easily swayed into this direction, why this particular approach to economic development and health was taken. And so the first question I want to ask is, going back to this distinction between the realist and the functionalist in international organizations, who were the experts? Who were the experts driving these sort of ideas? I want to stress first that health economics was in its infancy. It was a very new discipline, particularly as applied to the international field. Actually, there were very few centres in the 1970s and early 1980s, and most of them seem to have been very concentrated in the Ivy League in the American East Coast, and a few in Britain, like my own, the London School of Hygiene, Oxford University, and so on. So the experts were drawn from a very narrow range. It is not true to say they were all classical economists. Even in our interviews, we found people whose background was philosophy, literature, engineering. So they did come from a broad background. Our interviews also suggest their motives were diverse. They were not ideologically driven. A lot of them came out of that ferment of the 1960s in the United States. President Kennedy's enthusiasm for development, the Peace Corps, and so on. They tended to be people genuinely motivated by altruism. And our interviews also suggest to us that it was experience and observation, not theory, which really drove them. Were they acting as a transnational community of experts? Well, again, our interviews suggest that the experts did see themselves as not tied to their nation of citizenship. We were worried about everybody, said one of our interviewees. We weren't worried about the US. Part of what was interesting about being in the bank was how well you could become a sort of international person. And they also told us that the group of experts were very strong-minded. They were not the sort of people to be easily influenced and told what to think. That also sort of underpins the interview feedback we got on the people who wrote this particular document. For example, David de Ferranti was not remembered as a very ideological economist. Instead, he was remembered as a pretty pragmatic guy, not particularly pro or con markets, not believing that user fees were the solution to everything. One of the authors remembered to us that it looked like we were pushing prices to the world. We were saying only charge the rich people to get money into the system. So they feel they've been misinterpreted. Although Nancy Birdsall was particularly remembered as someone who certainly was committed to the what we might call the neoliberal turn, the economics of Hayek and Friedman. So just finally, what we want to emphasize then as part of our explanation is the nature of the institution and its situation in Washington, DC, the base of the bank in the US, and thus the US health system. And what we want to stress here is that the American health system was something of a model for the economists who worked for the bank. One of our interviewees from Britain noticed this particularly. The health system you're accustomed to frames how you think. In the US, it's a very individualist motivation, the hate of state intervention. And that was something that was supported by other oral history interviewees. The bank being located in Washington, the influence of American academic thinking was a lot stronger. If there was a model, it was private sector, and so on and so forth. So part of our argument then is that we can explain this not crudely in terms of ideology, but rather with the environment, the institution of the bank, which inclined people towards this more pluralist, more market approach to the health system. So summing up, to this question of whether we can simply say that the bank's approach was a product of ideology, we want to argue that that is too simple, it's too reductionist. First of all, we've stressed the continuities with earlier progressive thought. I hope you can see this slide here. And is it okay?
Is the conclusion?
Conclusion slide, yes.
Yes, that's okay.
And so we want to stress, first of all, the continuities with progressive thought and the emphasis the bank always had on addressing the problems of inequity. Its argument that the colonial systems that many poor countries had inherited had left those countries poorly provided, with too many hospital services in the cities, not enough service for the rural poor, and that the end of policy should be to try and correct those inequities. And also to emphasize that the bank, many of the experts at the bank were really pragmatists, doing what they thought was realistically needed. And we also wanted to emphasize that international health economics, which provided the empirical and theoretical basis for this, was a new and emergent discipline, and that indeed at this stage did provide some empirical basis for thinking that the user fees approach would be safe. But we do not want to present a revisionist answer to the familiar critique, because it is clear that the turn towards user fees did compromise multilateralism. We did find evidence of neoliberalism as an ideology at the top of the bank, but instead of that, what we've wanted to emphasize is the institutional setting and the research dominance of American health economists steeped in the American health system. And for that reason, our view is that alternative strategies, which may have been better for the poor, were sidelined. So thank you very much. That's the end of my presentation. Thank you for listening.
Thank you very much for the presentation. It was very, very easy to understanding. Thank you for talking slowly. And as I told you before, to hear you made me think how strong is our universal system in Brazil. It was built on the era of neoliberalism and the general idea of user fees for health services. So we could build the primary healthcare from 1990 until now, and it was very important on this pandemic, although less used than it could have been, especially because our community health workers did not receive masks and were not trained in preventive actions during the pandemics, but they were very important. The system, the unified system, the universal system, as you can say, it is very important for Brazil. And to listen to your presentation enforces the idea of the public health system, how important it is in a world where poverty is increasing every day. So thank you very much. It was very, very interesting. So we have two questions here, and I will try to translate to you. Is that possible?
Yes.
Okay, let's go. So there is a question talking about the global trend. Do the global trend to decrease funding for public health led by US and World Bank affect the England NHS? I think it's because in Brazil we admire the NHS. So I think the listener want to know about the survival of your NHS in this global trend, this world. Okay.
Yes. Okay. So at the same time in Britain, it was the period of Margaret Thatcher. She had the same philosophy as Ronald Reagan. her philosophy was to sell the nationalized industries like gas, electricity, water, coal to the private sector, to denationalize. In her early years, she commissioned a report to inquire into whether it would be possible to privatize the National Health Service. The civil servants who examined this looked at other countries. They looked at Europe, where there was an insurance approach. They looked at the United States, where there was Social Security plus private insurance. And they came back and actually said to Margaret Thatcher, the NHS is a very good model. It's efficient. It does not waste money on administration. It is equitable. And although its results are not the best in the world, it is quite acceptable for the British public. And it also pointed out that the NHS is extremely popular. There is a quote from the finance minister of Margaret Thatcher, Nigel Lawson, who said, "The British National Health Service is the closest thing the British have to a religion." In other words, people have great faith and they like it. So Mrs. Thatcher decided that it would be politically very dangerous to her to privatise the National Health Service. Therefore, she made small changes. First of all, to privatise parts of hospitals like cleaning, meals, food, etc. So there was some marginal privatisation. And secondly, they introduced what they called an internal market to make it, to try to mimic the dynamics of purchasing in a private system within the public NHS. So the primary care were given a budget and told that they should shop around between hospitals as if it was a market. So that did happen, but it did not change the fundamental public character of the National Health Service. That has come later, very slowly, where more commissioning from private providers has been permitted. And under the present government, there is a great use of the private sector to manage the COVID pandemic. So it seems now very likely that there will be an increase in the marketisation of the British National Health Service.
You see, there is a huge difference between our middle class and yours, because, you know, our middle class love the idea of being high class. So they want private services to show how they are like high class. It's different because we have here in Brazil a professor named Lígia Bahia, and she always says that our unified system had 6 months of happy when middle class could not to use what they pay for health services in taxes. So can you imagine the government allow us from middle class to pay less taxes to have private health insurance? It's horrible. But we could finish this only by 6 months in 1990, I think, I don't remember exactly, but only 6 months. And nowadays, people can use what they pay for private insurance with less taxes, which is horrible because it's a way to financing the private healthcare. It's like this, it's horrible. So it's very different, our middle class, unfortunately for us.
Yeah. In Britain, the National Health Service began in 1948, and this was before there was a strong health insurance industry. Therefore, private health insurance never became a pressure group on government. They never tried to influence policy. So before, so the public system was well established politically, and the middle class in Britain could appreciate that the universal healthcare from the public system was really just as good because the same doctors served in the public system and the private. So here there is private health insurance, but really it is only for greater comfort. You will go to a hospital, you will have your own private room, you will have nice food, etc. But the medical care will be the same. Therefore, it is less attractive. It's not a good deal financially.
No, thanks God. And there is another question here. I think it's about Tobin tax. I don't know if you remember this, that idea of controlling capital flows. I think the idea here is that this global trend is related to the uncontrolling capital flows. I think he wants to know if you think if we can control capital flows, it was easily to have resources to national systems of health and to finance the world, the UN too. I think it's here. It's it. The question is that. What about a tax like Tobin tax, a way of control capital flows, which could avoid volatility and maybe allow countries to control resources on national soil and also maybe finance UN actions?
Yes, it's a very good question. With respect to my paper and the 1980s, I don't know if it's part of that story. I don't think it's the case that global corporations at that time were really waiting for an opportunity to capture healthcare markets. I don't know. It may be possible. I'm not really sure. My impression is that that is something which has really come much later. So, for example, if I talk again about the British National Health Service, I mentioned that from the late 1990s and early 2000s, there was more privatization of contracts in the public system. So at that time, we saw the arrival from New Zealand of Southern Cross, which is a private insurance company that provides social care homes. We saw the arrival from the United States of Humana, which is I think a health maintenance organization from the US. So clearly, even in my own experience of my country, the globalization of the health industry is clearly a factor, and it does bear upon the decisions of national government. Yeah, that's really true. In none of the World Bank documents that I've looked at do I see evidence that this was part of their agenda. And I should say that the World Bank has moved clearly away from a strong advocacy of user fees. Their position at the moment is that really it is up to each individual nation to choose their approach. They take no dogmatic view, and there is a strand of thinking which accepts the successes of public sector medicine, tax-based medicine. And the argument is around fiscal space. In other words, if a country is developing its economy and has sufficient revenues to tax and to spend, the fiscal space, then it should go ahead and do that. So with regard to my paper, I don't think the bank has a strong agenda in that respect. There is, however, as part of the bank, another branch, the International Finance Corporation, and that is specifically dedicated to providing loans to help private sector development. In terms of the proportion of World Bank assistance which comes from that, I really don't know. But that is the area where you would find the bank supporting capital flows from private business for healthcare development. There are some good papers by Professor Devi Sridhar from the University of Edinburgh, and she has explored that.
And as we were talking before, do you think this pandemic can change? Because in Brazil, the neoliberalism is still very strong, very strong. I think as we had 12 years of left government, part of the journalists and economists wanted to change for a more liberal way to govern. So it's a tendency in Brazil, which in this pandemic became very, very bad. So it was, they were trying to not use the state to solve social problems. And the pandemic showed us that the state is necessary. Yeah. And so in Brazil, this is very, very strong. And but I think Brazil and US are in a different way from the rest of the world, because I think the rest of the world, especially Europe, are thinking in how important is a state acting in favor of poor people. So do you think this pandemic can change or strong the idea of the state, the strong state? Do you think it's possible?
Yes, if we look at the countries which have succeeded, of course, first of all, South Korea, China, Taiwan, where strong states imposed very strict controls very quickly. But amongst the liberal democracies, there has been quite a variation. Those which have low rates, for example, New Zealand, Australia, also Germany, were places which were able to use a good primary and community healthcare system. And this comes back, perhaps, Anna, to your first question and observation about COVID-19 and primary care. And those were places which, instead of relying on private contractors, were able to mobilize a system which was already working well within local municipal government, provided the expertise. So I think it certainly demonstrated that. In other parts of the world, like my country, we have a populist conservative government which has moved almost full circle from Thatcherism, from the beliefs of Margaret Thatcher, to embrace state action. And of course, they have provided social security, they have provided good support for people who are unemployed due to COVID. Huge expenditure has gone on welfare during the pandemic. So certainly the big state is back. However, as I was saying, so too are markets, and much of the spending has gone on private sector providers in some countries. So I don't know, it's easy to be pessimistic. Nonetheless, you know, Joe Biden has shown the possibilities to come back after the populist era of Trump, with a strong spending program, a strong focus on the green politics, and I think perhaps that will show us the way. But of course,
it's our...
who can predict where the politics, the popular politics, will go?
We are dreaming. So
we must dream.
Yes, we must dream. Especially in Brazil, we must dream because
or pray.
Yeah. Okay. So, Martin, I thank you very much for the presentation, for the conversation with the answers to the public. It was very, very interesting. And let me see if there is another question. I will ask in Portuguese for a minute, please.
Okay.
Tem alguma pergunta ainda, Taine? Eu perdi alguma pergunta, não?
Não, Ana, tudo certo.
Então tá bom. So that's it. I thank you very much for the presentation. I will send after the video with the translations because we will send the video of our seminars for another institutes to make a real conversation about problems of healthcare in all the world. I think it's important for us to change experiences. And the more we talk, the more we can
learn.
Melhorar, as you can say in Portuguese, but I think it's possible to change things talking and making pressures to the government. So thank you very much for being here. Thanks to the audience too for listening to us. Thank you.
Thank you very much for having me, and I hope one day I will see you in person and in the future.
Yes, next year, if the pandemic ends, next year. Thank you.
Okay.